And I'd like to thank the Africa Head and Neck Society for giving me this opportunity to present an interesting case of mouth tumor. Now, I am based in Machakos, but the patient is from UCT, or let me say Groote Hospital, which is in Cape Town. And I managed to observe the management of this patient during my observership last month. So we chose this case because I think it will bring out a good discussion on some of the salient features on the management of floor of mouth tumors, especially when the mandible is involved. And it would be interesting to see what our colleagues from around the continent do with such tumors as well. So, 1 second. Yeah. So the patient is TN. He's a 51-year-old male who was seen at the GSH hospital on the 10th of August 2021. He was referred to the ENT clinic, and that's the time that he was seen. And the referral was from the maxillofacial clinic. And he had presented with a history of an unhealing floor of mouth ulcer for the past 3 months. As he was being referred, there was a biopsy that had been taken by the maxillofacial surgeons, and the biopsy results showed a moderately well-differentiated squamous cell carcinoma. Now, he was a smoker and had a total of 30 pack years, and also history of taking alcohol as well during the same period. The ulcer was painful and was affecting his feeding, though he did not complain of significant weight loss. Past medical history, he's hypertensive, but well controlled, and he had a history of pulmonary TB treatment a while back. Now, on general examination, he was in fair general condition, was not in any respiratory distress, but on the oral examination, I found this sketch to be helpful. I saw it in the file of one of the, someone had drawn it, and I think it's kind of accurate of where the lesion was. It was a floor of mouth tumor. This is the tongue. This is the floor of mouth. This is the mandible. And the tumor was extending all the way to the anterior, the lingual gingiva, and it was crossing the midline. It was also involving the tongue, and there was a submucosal extension, or submucosal involvement of the tongue. And the mass itself was actually more on the left than on the right. But at the area of the mandible and at the tongue, it was crossing the midline. For the neck, there were multiple nodes on the left, the largest being a level 1B node, which was 2 by 2 centimeters, and had multiple sub-centimeter nodes at level 2 and 4. So the clinical staging at this point was T4A, N2B, and MX. He had a Panorex that was ordered and came back the same day. And from the Panorex, you can see that at the anterior mandible, you can see that there's an element of erosion as well. So there's actually mandibular involvement anteriorly. The chest X-ray was done. You could see that it was essentially normal. There were no features that were pointing towards a metastasis, and it was also hard to know that he had had treatment before. So sorry about that, but it's a T4A tumor because of the mandibular involvement, N2B because of the multiple nodes on the left, and the MO because of, you just took the chest X-ray to indicate whether there was a metastasis or not. And with that, he was booked for discussion at the LE32 clinic. Now the LE32 clinic in the GSH hospital is their multidisciplinary clinic. And the clinic, he was reviewed at the clinic about 10 days after the time he was seen at the ENT clinic. And a decision was made that he should undergo an excision, a wide excision of the tumor of the floor of mouth, together with a partial glossectomy because of the extension towards the tongue, and the segmental mandibulectomy due to the involvement of the anterior mandible, together with a bilateral modified radical neck dissection. And now, if you note, the surgery now was booked on the 29th of September. So from the time of being seen at early 32 to the time of the surgery, you notice it was about a month plus. And this is just purely because that was the closest date that they could find for him. And a decision was made in early 32 to give him what they call holding chemotherapy. And that constituted a cycle of carboplatin, which was given on the 30th of August. Now, it's interesting about the concept of holding chemotherapy. It's not necessarily to downgrade the tumor, but to somehow stop it from probably growing further, just to see if you can operate and get a better outcome if the tumor does not grow. Now, this is something I first have seen in UCT, and it would be very interesting to see how other departments also view this, or if they actually do this as well. Then now the surgery was booked and was done on the 29th of September 2021. And this is the surgical specimen. You can see this is the mandible, the excised mandible, together with the partial glossectomy, and the tumor at the floor of mouth as well. And he also had a bilateral modified radical neck dissection type 2. Now, this was the defect post-surgery. You can see the remnant of the tongue. And then you can also see bilaterally, hidden behind the skin flap here, you can see the mandible on the right and on the left. Now, the challenge here is how to reconstruct this defect. And I think for him, he was lucky. He was at GSH. They have a fantastic team with the plastic surgeons, and they were able to do a fibular free flap reconstruction with a skin paddle. I may not have the intraoperative images, but I have the image post-operatively. And I just chose this one, which is about 5 days post-op, because I think it says a lot. You can see the skin paddle. It was viable. The skin prick was, the color was good. It was easily bleeding as well. You can see the remnant of the tongue there. The drains were out by day 5. He was still on NG tube feeding. You can see that there was a tracheostomy that was put, but this is generally standard. I think in GSH, especially when the extent of surgery involving the mandible is large. Now, I think what I wanted us to focus on here was generally, one, the element of holding chemotherapy and the comments about it, and probably maybe experience about it as well. And then the element of the reconstruction. This was an anterior mandibular, I mean, the segmental mandibulectomy was anterior. So it was obviously crossing the midline, and they were able to do a free flap. But I wonder, in regions where maybe there's no free flap capability, how would they reconstruct this defect? Would you put a plate with a soft tissue, maybe a local regional flap like a pec major? And then also the other question is, does site of the excision matter, or the mandibulectomy matter? Would some people consider an anterior segmental mandibulectomy without the ability to do a fibular free flap as an irresectable tumor? So I think that was generally the presentation, and comments are invited on any of these discussion points. Thank you.
Thank you very much, Samuel. Very interesting case presentation, and I'm very excited to hear about the holding chemotherapy. If there is any oncology person present on this platform, and of course, obviously, there is a reconstructive part that if there is any plastic surgeon can comment on this.
Anna, can I ask Samira Dalby to comment on the holding chemotherapy issue? Please, some
Yes, please. Thank you, Prof.
So yes, we use what we call holding chemotherapy in Ali32. We find that if we do give the chemotherapy, it keeps the patient still operable. It's been, obviously the regimen used is also dependent on the patient and their comorbidities and what they can actually tolerate. There is obviously the risk that you can have a dramatic response, and then the pathological staging after surgery might be different. But then we'd always look at what the clinical staging was before giving the chemotherapy when making a decision on adjuvant therapy. So it's something that we use, especially when there's a long waiting list as a temporizing measure. We often use chemotherapy as a temporizing measure before radiotherapy as well.
Yes, thank you, Samira. Maybe also
Samira, can I ask you a question? Sorry, Samuel. Is holding chemotherapy and neoadjuvant chemotherapy, how different it is?
So the neoadjuvant chemotherapy for many sites would probably be 3 cycles. And many times it's the regimens are at least 2 agents. Here with this patient, we see just 1 agent being used. And I know Julie Vetter that runs the clinic, sometimes she'll use single agent methotrexate as well. So it's usually not the full dose that one sees with the neoadjuvant chemotherapy. There's also, we don't want too much toxicity, that when the patient gets to surgery, they've had so much toxicity and they have a complicated post-operative course.
All right, thank you, Samira. Can I ask you one more question? Was there any study done to show the results of holding chemotherapy?
No, it's just institutional practice. It's what we've found works for us, because in the past, sometimes with such long waiting lists, we would find that the patient has become inoperable. And using this, we've seen in our practice that they actually keep the surgical status, that they are still operable. I can't tell you whether this changes survival. I'm not sure.
All right, thank you very much. That was very interesting for us to hear.
Thank you.
Thank
Anna,
you.
can I ask Mr. Patrick Bradley to comment? Patrick, just to give you some background, so it's the role of giving chemotherapy to try and hold a tumor from progressing while the patient awaits surgery. Do you have any comments on that?
Johan, I've just arrived and I've missed most of the case presentation, but I do think that unless you accumulate your own evidence as to pre-staging or pre-holding chemotherapy, you really have no idea. It's kind of quelling your conscience, and I'm afraid we need more objective evidence as to why we do that. I think I really am very suspicious of wasting very, expensive medicine for palliation and conscience. And that's my very limited view.
If we use it only in cases where the waiting list might be 6 weeks or 2 months, and the patient is borderline operable, and we're concerned that by the time they come to surgery, they will not be operable anymore. So it's so that's the kind of setting where we would use it.
I'm not saying you're not using it, but in my department, we didn't have a waiting list of less than 4, or all surgery happened within 4 weeks of making a decision. If for any reason it went beyond that, then we would review the case, restage the case, and then make a new decision. Maybe you can't do that in your environment.
Yeah. Joyce, are you doing it in Kenya?
Once in a while, if we can convince the oncologist, we can. Soon after I left Cape Town, we tried methotrexate, but we didn't get a lot of support from the oncologist to continue using it. They actually prefer to use newer drugs, and they actually prefer giving it as a neoadjuvant rather than holding.
Yeah, probably neoadjuvant. Yeah. Am I still live?
You are?
I think neoadjuvant at least is part of a trial. I think that should be used as a trial experimentation, if you call it that. But I think you then need to collect the information as to what effect that has had, because I think as clinicians, we know that not every case is similar. Some do respond, some don't respond. And I think we need to get more evidence about the tumor activity and other pathological parameters to decide why we're giving chemo. And, you know, I know our back is to the wall on economics, but at the same time, we've got to use our resources more objectively than emotionally. I'm sorry. I'm an old man. I've seen all of this money wasted without any evidence at all. And that's it. I mean, I'm finished. Thanks.
Yeah, thanks. Yeah.
Yeah. Okay.
Yeah, could you ask Ahmad from Egypt? Ahmad, do you use it in Egypt at all?
Welcome, Dr. Fagan. No, we don't.
Yeah, so if you have a borderline operable case and you've got a long waiting list, what do you do with them?
To say the least, I don't have a very big experience with that actually, but I would tell you, yes, I would try it. Why not? If we have the resources, and most of the time we do have them, I would use it. Why not? Sorry, I didn't get that.
No. So, what about you? No, man.
Oh, can you hear me? Hello?
Go ahead. Rana, you better take over.
Yeah, I think I'm not seeing where to mute some of the participants who are making noise, but I think we have 3 case presentation. Maybe we should go to the next discussion about the reconstruction on plate or soft tissues with local regional flaps versus the free fibular flap. If there is anyone on this platform who have experience in those reconstruction, and please share the experience with us.
Can I ask, Samuel, can you kindly stop sharing your screen so that we can have the next case speakers share their screen? And I've muted the participant that was a bit noisy.
Thank you.
Anna, can I start the conversation just by saying that that as Samuel said, we're fortunate because we have good reconstructive surgeons available. But I'm really interested to know what surgeons do elsewhere in Africa, or oncologists for that matter, when the tumor crosses the midline of the mandible. Do they consider the patients inoperable, or do they use a plate to reconstruct it? And what's the experience from that perspective?
Prof, is this question to me or to everyone?
No, to everyone, because I think it's quite a common dilemma, and I'm just interested to know how they would have managed this patient. What do you do, Anna?
Well, Prof, it can be. I can say that not all the cases I'll do the same. Maybe some cases that I need to resect and see if there is any tumor recurrence or not, since the frozen sections are not available, and reconstructions too are a bit difficult with the free flaps. We do resections, and then if the tumor out and the wounds heal, see if there is recurrence or not, then we think about the reconstructions later with the plates. I know the maxillofacial unit, they use a lot of rib reconstruction with the rib graft. They claim the results are good, though I don't know if there is any bone resorption over time. But recently I've seen one tumor they just removed the whole mandible, and then the patient, though it was a bit deformed, but he was happy there was no tumor. Prof, there are situations where I always say that if you put on a scale your life and then the disease, what would you choose, to have a beauty or have the disease? So some patients understand, but some patients, the choice not to have any deformity, and they don't want to, let's say, they don't want to have a larynx to remove, and at the same time there is a tumor sitting there, and they prefer to have tracheostomy and not laryngectomy. There are a lot of consideration of what to do during to plan for patient surgery. So there are multiple factors play a role in it.
Chege, do you want to comment?
Yes, I do. Hi, Prof. Hi, everyone. Sam, that was an excellent presentation. I really would have wanted to see the actual preoperative images just to see how it looks, but the picture that was shared, you're right, was quite adequately graphic. Now, maybe just to start off with a question, because looking at the picture, Sam, that you've shared, and the OPG, it looks like a bit of the central mandible, just around the incisors, was affected. So, because I've had a few cases like this where, looking at the images that you'd shared, immediately I was trying to play in my mind what we would have done in the absence of assistance from plastic surgery. And intraoperatively, it looks like, man, they took the mandible, was it angle to angle? and that, I mean, that looks quite big, quite a huge resection compared to the images that were shared, unless I'm wrong. And also the tongue. So I don't know. Sometimes, in my experience, when I don't have reconstructive options, I find I'm probably, and this of course I stand to be corrected. Sometimes I find I'm likely to be less aggressive in terms of how far I take out the margins. you know, I'd want to look, you know, looking at that OPG, the first thing in my mind is, can we get away with a marginal mandibulectomy and kind of live maybe just like 0.5 centimeter of, you know, of the lower margin, of the lower cortex of the mandible, and maybe even reinforce that with a titanium plate, a recon plate, 2.3, 2.4, something big and strong, but take out, you know, marginal mandible with the entire specimen, maybe from second molar to, you know, from first or second molar to first or second molar on the other side. Now, in terms of reconstructive options, we've been able to fairly well reconstruct the floor of mouth with supraclavicular flaps. Of course, there are all sorts of other flap options, but that works really well actually for the floor of mouth, even in terms of reach, and you know, it's a fairly robust flap. Yeah, but as for the mandible, if the mandible really has to go and you don't have free flap options, a free flap would still be the best. As Anna has said, some have used free bone grafts, though they do tend to resorb over time. Yeah, but probably that's what I would say for now.
And could I comment? So you're right, because we are reconstructing with free bone flaps, you know, we can afford to be more aggressive. We do regret it when we have flap failures, which happens in all units from time to time, and that can be an absolute disaster for this kind of case. But you want to get a good margin, and I'm not sure that non-vascularized bone is going to be good in a situation where the patient needs post-operative radiotherapy. So that's why we wouldn't favor using a non-vascularized bone.
And might I ask, I don't know if anyone has had experience with this. I just read it once. I've come across it once where there was use of a pectoralis major flap that was lifted together with the outer cortex of the sternum, and that would be quote unquote vascularized bone. It didn't make sense to me at all, but this was published somewhere. I don't know if anyone on this forum has had experience using that.
Good afternoon.
Hi, Ken.
Yes, thank you for the presentation. In answering, partly answering Chege's question, we recently, I think in about 2 months ago, we did something similar, and we used a PEC major flap, but then with the titanium plates, then with the rib cartilage. We took a rib to reinforce the plate, but then we covered the cover was with a PEC major with skin. So, and our patient is doing well. We're hoping one of these they would have shared with you, but then it's okay. So I think it's doable.
Yeah, perhaps we can ask the old man, Pat Bradley, who's probably seen most things. Pat, have you got experience with the rib with a PEC major flap?
No is the simple answer. We would use clavicle, but it may not be long enough is always the problem. I must say, I resorted to getting maxillofacial surgeons to help me close those holes. It is very difficult to know when you cross the midline as to how to accept it. You either accept the old composite anti-Gumpf deformity and then consider a secondary repair, assuming the patient lives 6 months plus without recurrence, and then consider putting in another graft. I'm not very helpful in the modern era. Have we lost somewhere?
We are all here. I think we are.
Yeah, do you want Simon to continue?
Yeah, Prof. I just had one last slide, but I did not want to eat too much time on my other colleagues' time. Let me see if I can just quickly share it. One minute. But basically, it was about a study that was done, that was published recently, on the different techniques of repair or of the mandible reconstruction. And basically, not really different techniques, but just two, either the free fibular flap or the soft tissue with plates. And this is a study, Complications After Soft Tissue with Plate versus Bony Mandibular Reconstruction. This was by Eric Bauer, published, or at least I managed to get the paper this last week. But basically it was a systematic review, and the median follow-up was 12 months post-surgery. And they were looking at two complications, either plate exposure or fracture of plate. And basically, the fibular free flap fared better than soft tissue plus plate. And maybe what is more significant is the need for revision surgery. It was twice as much for the soft tissue and plate repair versus the free fibular flap. The only thing is that they didn't mention the sites of the repair. So it was neither, they didn't mention whether it was anterior or lateral or not. I mean, we just based on different work environments, I think I stand corrected, but we would have to offer the patient what we are able to offer. That's the end of my presentation.
See if I can find something else to do apart from WhatsApp. Na naunda do, itakuwa poa.
Unless you know the numbers of patients who underwent both sides of that publication, there's no conclusion you can take. Maybe they're better at doing fibular free flaps, and the rest, the soft tissue and plates, is retrospective. It's very difficult to make any conclusions out of that publication.
Yeah, I think on one hand, free fibula was about 1,000 plus patients, and the soft tissue was about 800. But you're right, they did not. There was no like comparison with a p-value of the different sides, so they said it was not really statistical.
Yeah, they would, wouldn't they? Yeah.
Thank you so much.
Thank you, Samuel.
This is Dr. Myers. Can you hear me?
Yes, Dr. Maya.
Yeah. It's a very difficult case, obviously, and I've lived through the different types of reconstruction of the mandible, and I can tell you that no matter what we use, whether it would be metal plate or plastic or radiated bone or whatever it was that we put in, you could be pretty sure that we'd be taking it out before too long. It's a foreign body and it doesn't do well, particularly if this would be a patient who you would certainly want to radiate, and that would be, I think, raise the chances of extrusion of the metal plate. So I think that we've seen the wonderful results with free flaps that we never saw with just plates and so forth. And so That's the whole changed the whole way of managing these patients with advanced cancers.
Thanks for sharing with us. Thank you. I think we are moving to the next presentation from Cape Town, South Africa. Prof.
Divya, can you share your screen? Thanks very much.
Thank you.
Melanoma is really
Divya, you can start. Divya, can you unmute your microphone?
Sorry about that. Can you hear me?
I can hear you loud and clear. You can go ahead.
Thank you. Right, I'm Dr. Divya Ramyead, an ENT registrar at the University of Cape Town. Today I'll be presenting on a head and neck cutaneous melanoma case. A 65-year-old gentleman presented with a melanoma over his right temporal scalp area. He reports of an initial excision done in November 2020 with close deep margins of less than 1 millimeter, but there was no prior formal staging done at that point. His history goes he has no complaints of odynophagia, facial weakness, loss of appetite, or loss of weight. He's got no past medical history. In post-surgical history, he had laser surgery on detached retina, a right arm basal cell carcinoma, excision, and a left knee operation. Social history, he's a non-smoker and an occasional alcoholic. On general examination, while the ear, nose, and oral cavity was normal, his facial nerve was intact, but what was noted was a 1 centimeter hard, immobile preauricular nodule on the right side. On neck palpation, there was no palpable lymph nodes. We proceeded to do blood results, which came out normal. HIV test was negative, and a PET CT scan as well as a CT scan was arranged for him. The PET CT scan revealed right cervical and preauricular lymphadenopathy in keeping with regional nodal involvement, but it also showed that there was a left upper lobe nodule. And CT scan similarly identified right parotid superficial lobe involvement, 17 by 14 millimeters, and a rounded pulmonary nodule in the left upper lobe anteriorly. This is his chest X-ray, and it is how the CT scan of his chest. And here we can see the little round pulmonary nodule over his chest. So now we are faced with a gentleman, 65 years old, who had an excision of his right temporal melanoma. It comes up now with lymph nodes as well as a lung metastasis. So now the decision that we face is what to do next. And before I go forward as to what we did and a little literature review on melanomas, I'd like to open this question to the floor as what are your views for the next step? Would you go for operation for local control or radiotherapy because of the poor prognosis with lung metastasis? Yes.
Chege, what is your opinion on this one? Would you operate?
Yes. No.
I think I would subject this to MDT first, but I'd be inclined to operate.
Go on, operate.
Yeah. Are there any oncologists on the call who might on the meeting who might want to comment?
I hope not.
Mr. Mira?
I thought maybe there's someone else who wants to comment. So just to put it in our local context, we don't have access to immune therapy or targeted agents. So really, for the melanoma patients, we really restricted in what we can offer them unless we can get them on a trial, then they might have access to immune therapy. And just with one small lesion seen on the PET CT, the patient could live for at least more than a year, maybe 2 years or so. And, in the head and neck, if you've got a tumor that's not controlled, it does have a considerable impact on morbidity and, the quality of life of someone who's not going to die immediately from the metastasis. We only have DTIC available, which is really something that's nobody else uses because it has no survival benefit. The only benefit for DTIC chemotherapy is it's got a response rate of about 30%, and that 30% includes complete and partial response. So, but it's never been proven to have an overall survival benefit. So, for most patients, if we can have some local control to improve quality of life, that's what we try and do. With the radiotherapy as well, which is given in the adjuvant setting after lymph node dissection. The benefit of the radiotherapy is also purely for in-field control. It has no impact on overall survival or distant metastasis-free survival. So we're very careful to inform the patients of exactly what the benefit is, and they make a decision based on that. Yeah.
There's a comment from Dr. Ellen Boulding saying definitive surgery with neck dissection.
Well, can I interject? What about his parotid? Would you not do a lateral parotidectomy or reevaluate the deep lobe of his parotid as to whether it's involved? And consider doing a selective neck dissection if clinically he hasn't got radiologic or pathologic neck disease. I think you're into a potential palliative situation with unrealistic outcome for his neck or for his lung metastasis. I think you've got to wait and see what happens with his lung. I'm not sure where the role of immunotherapy is in this case at this stage.
Dr. Boulding, do you want to comment?
Sure. As a non-oncologist and non-surgeon, but in terms of controlling local disease, I would definitely dissect. He was never really staged properly. Surgery at this stage is definitely his best chance for controlling local disease. So I would definitely do the lymph nodes of the neck. I would definitely do the parotid gland. I would watch the lung met. I mean, if it's an isolated lung met, I would still probably consider surgery if there's no immunotherapy around. I mean, patients with metastatic melanoma do pretty well on immunotherapy, but that's beyond the scope of many people. So I think his best chance in preventing local disease and complications thereof are definitely surgical. Thanks.
Okay. Divya, do you want to proceed?
Yeah, sure.
If you're going to operate on the patient, I would also suggest operating on the primary because he only had a millimeter of clear margin, And I think that there has a potential to recur in the primary site. So I would, while you're doing all the rest of the nodes and parotid, I would suggest that resecting the primary. The other thing is that I think in the presentation, it was, if I understood it correctly, that the mass in the parotid gland was fixed. Is that correct?
Yes, yeah, it was fixed.
Then a total parotidectomy is what he needs, with facial nerve preservation.
That's right, but also I think the patient has to be counseled on the possibility of facial nerve reconstruction, because if you have a fixed mass in the parotid, you're going to probably end up taking the facial nerve.
Gene, what a wise man you are.
Okay, Divya, you want to proceed?
Yeah, sure.
I did 1,500 parotidectomies in my active days, so I've seen a few ugly cases like this.
Okay, Divya.
So in our MDT meeting, we went and proceeded to go ahead with local control. A re-excision of the right temporal skin area melanoma was done, together with a right total parotidectomy and a right modified radical neck dissection type 2. As we can see here in the picture on the right, a modified Blair incision was done with extension to the lower neck and supraclavicular region with skin flap elevation. And this was done in order to fill in the defect in the superior part. Findings intraoperatively included multiple superficial and deep parotid lymph nodes. And while dissecting out the temporal skin melanoma, frontal branches of the facial nerve were preserved, and excision of the lesion was done up to the temporalis muscle fascia. The biopsy results came out showing in the right parotid metastatic melanoma. The skin of the face on the right side was, however, negative for residual melanoma. His right facial lymph node dissection was negative for malignancy, but the neck dissection was positive for lymph node metastasis, 2 out of 31 lymph nodes. The plan for this patient.
Divya, did you didn't mention anything about extracapsular spread? Was there any note on extracapsular spread?
No, there was no note on extracapsular spread on the HPE.
How many nodes in his parotid were positive?
2 out of 31 lymph nodes.
No, that's his neck, his parotid.
Yes.
How many parotid nodes were positive? And the size?
No,
Okay,
I'm not sure of that.
Don't worry. Don't worry.
So now the plan for the patient, he is for follow-up at the clinic. He's got a CT scan of the chest booked in order to have a surveillance on his lung involvement, and radiotherapy is planned for him. So a quick summary of what I found in the literature regarding melanoma. It is the most lethal skin tumor, and most common sites are the face, scalp, neck, and ear, but the scalp carries the worst prognosis. And important risk factors to look out is UV light exposure, patients that are fair-skinned with blue eyes. And on examination, we always follow the ABCDE mnemonic, which helps us to differentiate between benign and malignant skin lesions. And obviously, ulceration, nodularity, and satellite lesions would suggest a more advanced disease. On examination, the nodes that we should look out for, especially if the melanoma is on the anterior scalp, temple, and cheek, is the parotid. And for those lesions that are on the posterior scalp and retroauricular occipital lymph nodes needs to be seen. And a metastatic workup is very important in patients with regional disease, and that includes CT, chest, abdomen, pelvis with IV contrast, MRI of the brain, and a PET CT, which is shown to be extremely sensitive and specific. And the reason for why we need to know metastasis is because of the 5-year survival rate. If it's a localized disease, it's 99%. If it's regional, it's 62.2%. And if it's metastatic, it drops down to 27.3%. And the prognosis obviously depends on the staging of the disease and is also related to the breast loads index. And we have, in summary, some favorable and unfavorable prognostic factors. And among the unfavorable prognostic factors are elderly males with head and neck and high breast load depth. And this is a little, a nice paper I found on diagnosis and management of cutaneous head and neck melanomas. And they nicely elicit on surgical margins the staging of melanomas, and the treatment being wide surgical excision, sentinel lymph node biopsy, adjuvant systemic therapy, starting from stage 3 melanomas, chemotherapy, and radiotherapy. They also mentioned that neck dissection is carried out with a vertical, imagining a vertical line passing through the external auditory canal with dissection level 1 to 4 performed if it's anterior to the line, or and level group 5 neck nodes included if it is posterior. And finally, just to conclude, what's the role of radiotherapy in management of melanoma? Contrary to what initially was thought, that melanomas are radioresistant, studies have shown that fractionated doses can be used, but RT is not to be used as an initial primary curative treatment. So adjuvant radiation is very useful after lymphadenectomy if parotid metastasis is noted. Also, if there are 2 or more positive cervical lymph nodes, if there are metastatic lymph nodes more than 3 centimeters, extranodal spread, or if neck dissection cannot be performed. In a paper in 1999 regarding palliative radiotherapy for recurrent and metastatic malignancy, they noted that lung metastasis from malignant melanomas are rare, and those patients who did receive radiotherapy for symptomatic pulmonary involvement had a short median survival of 5.3 months. And in another paper where of metastatic melanoma to the thorax, they found that if there's a solitary pulmonary nodule, the lesion is to be followed radiographically to determine the doubling time. If the doubling time is greater than 30 days, then the patient is given a combination chemotherapy. And if there are no other lesions, wedge resection of lung mass is indicated. And to end, how to follow up a patient with metastatic, with the cutaneous melanomas in the head and neck region. Patients staged 2B to 4 melanomas need follow-up every 3 to 6 months for 2 years, and then 3 to 12 monthly, and then annually, with chest X-ray, CT scan, brain MRI to be considered every 3 to 12 months, depending on the risk factors for recurrence. Thank you.
Thank you very much.
Prof Hiller has his hand raised for comment.
Yes, please.
Well done.
Yes, hello. Good day. Thank you very much for your comprehensive review. I have a bit of problem with your accent.
Sorry, I'm in Cape Town.
Melanoma or melanoma, whatever it is, it sounds a bit difficult to follow you. So I think it would be very good to make sure that your intonation of your medical terms is understandable by everybody. But that's beside the point. I have a question. Does anybody know if there is a difference in extranodular spread, extracapsular spread for melanomas and for squamous cell carcinoma in terms of A, how you measure it, and B, is there a difference in outcome regarding of this extracapsular phenomenon?
My understanding is that in terms of extracapsular extension, there isn't a huge difference in prognosis. Obviously, it in terms of overall survival, but the concern is around local control in terms of, nodal involvement.
Yeah, but for us pathologists, we can measure, for example, minor and major for squamous cell carcinoma. That's well documented, and it's also coming into the stage. But for melanomas, I don't have any data. Or does anybody know how to do this properly, or is it just extracapsular versus intranodal presence? What we have to mention in our reports.
Dr. Bolden, do you want to comment?
Yes, I think Georgina really has summarized it well. We always report melanomas with extranodal extension, and we usually give a measurement. If it's more than 2 or 3 millimeters, the chance of there's an increased risk of local recurrence. It does not, as far as we are aware, impact on long-term survival. It's more local recurrence, and then they may give additional radiotherapy to that area, particularly if it's like an axillary lymph node or whatever. So it's more to do with the increased risk of local recurrence.
Melissa, Melissa, do you want to comment?
Good evening, everybody. Good evening, Prof. Mine is not a comment, rather it's a question. What is the place of radiotherapy in patients with closed margin? For example, this patient, he had 1 millimeter closed margin in his initial surgery in November 2020. So, do you think he would have benefited from radiotherapy if he had radiotherapy after the surgery? Thank you.
Georgina, do you want to comment on that?
Yeah, sure, Johan. I mean, I think in terms of local radiotherapy, we would really look at close margins where one can't get wider clearance because of cosmetic reasons or functional reasons. So, it's often in the head and neck area, if further surgery to get a wide clearance would be a very morbid procedure. But overall, local radiation really impacts on local control and not overall survival. But local control in the head and neck area, as we know, can be very important in terms of quality of life.
And Georgina, do you want to comment on this patient who had a solitary lung metastasis, where we operated on the primary site and the neck? How would you manage that lung metastasis?
Yeah, sorry, I've just joined the meeting because I was busy, and I'm sorry I've joined so late, so I haven't heard all the discussion. But in terms of a single solitary lung metastasis, if it was amenable to resection, then one would certainly consider a thoracotomy and resection of that lesion. And then one would also consider adjuvant therapy with either a BRAF inhibitor if the patient has a BRAF mutation in the melanoma, or immunotherapy with something like pembrolizumab or nivolumab for a year post-resection of a metastatic lesion from melanoma.
But we don't know whether it's melanoma or an incidentaloma. You're making an assumption. I think we need to follow this patient with serial chest imaging to decide whether or not it is progressive.
What size is the lesion in the lung?
But we're told it's in the lung.
Yes, Samira, do you want to comment?
Yes, the patient's going to be discussed at the combined bronchus clinic on Monday with a view to seeing if it's possible to sample some of that tissue to ascertain whether it is a metastasis, or not.
Mm. I mean, obviously, if it's not amenable to fine needle aspiration biopsy or true cut biopsy, then it makes, if it's a small lesion, it makes sense to do serial CTs to follow them up and see if there's progression. Then obviously one would consider a thoracotomy to excise it.
Yeah, absolutely. Thank you.
There is a hand raised for comment from Dr. Ahmed Leteli. I hope that's pronounced correctly.
El Teleti.
I apologize.
No problems. I had some major technical issues initially with the meeting. I'm sorry. Actually, I got a question about wound closure. From the image that I saw, looks like it was a cervical advancement flap. Was that correct?
That's correct. That's correct. Yeah. Well, that's the flap we use. You know, so we send the parotid incision all the way down the trapezius and then over the clavicle area. Yeah.
Okay. Thank you.
There's just a comment for Dr. Musa saying, thank you to the presenter for the great presentation. The thought was that surgery is not likely to have an effect on the prognosis in this case, but it's just a thank you for the presentation, Divya.
Anna, do you want me to present my case?
Yes, Prof, we can proceed to the next. We have less than 20 minutes for the...
Yeah, mine's a quick one, yeah. Let me share it there. Yes, can you see that nicely?
No.
Right.
Yes, Prof, just you can click on presenter mode.
Yeah, you can see it?
Yes, Prof.
Yeah. Okay. Yeah, this is a patient we actually did yesterday, and I'm not certain that I did the right thing, so I thought I'd expose myself to an international audience and either be supported or be shot down. So this is a 60-year-old female, fair skinned, who lives, who works on game parks, and so she's exposed to the sun a lot. And she was referred to me from a neighboring country with a left parotid mass present for about 7 months. It had been growing quite rapidly. She had no pain associated with it. And she gives a history of having had a previous excision of a so-called BCC of the infraorbital skin. But I have no access to that original pathology report. And on examination, she had quite a large, about a 3 centimeter sort of rockable preauricular mass. I wasn't certain whether she had extremely early weakness of the facial nerve, and there were no skin cancers I could see in the head and neck area, and no palpable cervical nodes. She had an ultrasound done which showed 2 heterogeneous, predominantly solid parotid masses measuring 3 centimeters and 1.5 centimeters in diameter, which the ultrasonographer said had non-benign features. Not sure what they meant by that. And Dr. Boulding, do you want to just comment on the fine needle aspiration cytology?
Yes. Now, this presumably came from the parotid, hey, Johannes?
Yes, it did. It came from that mass done under ultrasound-guided fine needle. Was reported on bio competition.
Can you see my arrows? No, because I'm probably not sharing. Anyway, it doesn't matter. So these slides are all abnormal for the parotid gland. Slide A definitely shows some sort of tumor, which is quite thick and a bit overstained. Slide B shows a few atypical squamous cells in the background with a large foreign body giant cell. slides C and D both show what look like malignant tumor. There's no obvious glandular differentiation. You can't really see a lot of keratin or keratinizing squamous cells in the background, but without doubt, these pictures are malignant cytologically with a foreign body giant cell response, which you often see in squamous carcinomas where the foreign bodies react, where you get foreign body reaction to free-lying keratin. So there's no doubt that this is a malignant, malignant metastasis. It looks a bit squamoid. It certainly doesn't look like a basal cell carcinoma, and it doesn't look like a basaloid squam. So I would have reported this as malignant in keeping with a metastasis and probably or possibly of squamous cell carcinoma origin.
Well, thank you very much. Yeah, so that's what what the other pathologists had reported. So my assumption therefore was that I think the skin cancer was possibly a squamous carcinoma or a basal squam, and I made the assumption that we were dealing with intraparotid lymph nodes. So I proceeded to operate on the patient yesterday, and so the intraoperative pictures, you can see that I did a neck dissection, I did a selective neck dissection, but you see that on elevating the tumor off the node, there was tumor both deep and superficial to the facial nerve branches, and so and as I went forwards, you know, the facial nerve was actually quite well preserved. It didn't have that typical infiltrated look about it, and so I proceeded to peel node out of tumor rather than to resect it. And so that's really the controversy: is what you do when you have tumor sort of entering a squamous cell carcinoma metastasis as opposed to a salivary gland tumor. Is it okay to try and preserve the nerve as I did here? You can see this is at the end of the surgery. I've resected masseter. Onto the bone. I resected the capsule of the temporomandibular joint onto zygoma. I resected this branch here of the facial nerve, but there's a cross branch which hopefully will supply that, but managed to preserve all the other branches. So, and then did a selective neck dissection. And Ellen, do you want to comment on the pathology report?
Sure. The selective neck dissection was all very small, multiple small, very reactive nodes. You did the superficial and the deep parotid and the capsule of the TM joint. Both the superficial and the deep lobe of the parotid had metastatic squamous carcinoma in it with some cystic change. In the superficial lobe, it went to the deep margin. In the deep lobe of the parotid, there was tumor involved, which invaded fragments of the masseter muscle, but the deep masseteric margin was clear. There was also tumor around some of the nerves that were still in the parotid gland, not obviously the big facial nerve, but there was no true perineural invasion. So there was tumor encasing small remnants of nerve, but no frank perineural invasion that I could find. And the resection margins were clear. The TM joint, the capsule was uninvolved. It was just very thick capsular material, but no tumor in them. So she had a metastatic, moderately to poorly differentiated squamous carcinoma involving both the superficial and the deep parotid lobes, with no obvious perineural invasion, but with invasion of the superficial fragments of the masseter muscle, which were attached to the deep lobe.
Thank you. Yeah, so that's the question I want to throw open to the floor. Really, is did I do the right thing by trying to preserve facial nerve dissecting through, the soft metastatic squamous cell carcinoma nodes, or should I have sacrificed the facial nerve? And I'd just be interested to know what other people think about this.
What's your facial nerve function like now post-operatively?
Well, the facial nerve is a bit weak from all the work I've done on it. You know, she's got reasonable eye closure. She's got a weak mouth, but that should recover. And I expect to have full recovery, except perhaps just the mid-facial buccal branch.
And you're going to give her post-operative radiotherapy anyway?
Absolutely, because she's got, I mean, she must have microscopic tumor remaining.
What about the primary lesion that was called a BCC? Was there any reason to consider that was still active?
No, you know, and she will be radiated anyway.
What, our original BCC?
No. What I'm saying is the scar from the previous surgery is, you know, it will be in the radiation field.
Okay. Good luck.
Chege, you got a comment?
Yeah, I get. Of course, caveat: we're your students here, so you know I've spent quite some time looking at that the image after the dissection. I'm like, that looks really nicely done. I want to do that as well. But I'd imagine the two components of information here that one would have gone in with. First is the preoperative facial nerve function, which was largely preserved. And secondly, intraoperatively, they simply, you know, the nerve was, it just looked like it was uninvolved with tumor. So I think it was the right, I genuinely think it was the right call to preserve the nerve. This was really nicely done. Thank you. And I've taken a screenshot for my learning.
Yes, if you had to extrapolate this to the neck, if I'd had the same situation in the posterior triangle involving the accessory nerve, I would have sacrificed that. You know, because that would be our teaching. But here I was most certainly breaking my own rules, and I was just uncomfortable with doing it. So that's why I'm throwing open to the floor.
No, you're a senior surgeon, Johan. You make decisions.
Well, it's a long time now that we've gotten away from resecting the facial nerve, even if the nerve was encased with tumor, and it's been shown many times in many studies that the use of radiation therapy allows you to do that because it's able to kill whatever malignant cells might remain, and it's functionally the patient having functionality of the facial nerve due to the preservation of the nerve itself is a real gift to them. And I know when I first started out, the rule in such case like this was to take everything, take the facial nerve, take all the deep muscle, the masseter muscle, maybe the mandible and everything. But we've gotten away from that over the years. And we know from the beginning in this case that the patient was going to end up with radiation therapy. So you want to start out doing everything you can to preserve the nerve. It's a very, very nice dissection, Johan.
Well, I've learned from the master, Dr. Myers.
Jean, can I thank you for those words of wisdom? I totally agree with you. Times have changed and we need to move on.
Yep. Okay, Patrick, I'm glad to hear you agree.
Yeah, Dr. McAdam, I mean, you've got a special interest in skin cancers. Do you have any comments about this, Georgina?
Yeah, I mean, Johanna, I certainly agree that it wouldn't have made sense to sacrifice facial nerve because squamous cell cancer of the skin are relatively sensitive to radiotherapy. And given the fact that the patient is going to require and there wasn't any involvement of the major branches of the facial nerve. So I think it's perfectly reasonable to have preserved the facial nerve, and then we follow on with post-operative radiotherapy, which should hopefully give a good level of local control for this patient.
Okay.
Dr. Fagan?
Prof,
Was it easy dissection? Was it a straightforward dissection? Were you able to separate the tumor without leaving any gross residual tumor on the nerve sheath?
Yeah, well, as I said, I was dissecting through tumor, and it was the typical pasty, so necrotic tumor one was working through. So I know that there must be microscopic sort of disease, but I didn't leave any macroscopic disease behind.
So I think you made the right decision. Well done.
Yeah. And I've got nothing more to say. So back to you.
Okay. Okay, Prof, that's very nice pictures. And then for those who are seeing here, some are residents and they're learning. It's a nice teaching materials you are showing to us, and we really appreciate the pictures showing here, especially the drawing. When you don't have anything to show, as you have done intraoperative photos, some are drawings are very, very nice to show for you to like put in the head and in a picture form as to compare someone is describing in words. I think that it's really nice to present in that way. And there is a question to the previous presenter who said that I thank the presenter for this beautiful presentation, and I wonder why local control is the major consideration in a patient with lung metastasis about the melanoma case. And I thought the surgery is not likely to have affected the prognosis in this case. Sent by Yemisi Amusa to us. I don't know, Prof, do you want to answer the question?
Yeah, perhaps just to say that the objective of our surgery with the melanoma case wasn't to influence the survival necessarily, but to gain local control, because there's nothing worse than to have a large fungating mass on the face, and so it's about quality of life.
Absolutely, yeah.
I think that, incidentally, I'd like to comment on that. I know that there are various ideas about, watch and wait or something like that, but I think that the patient's overall safety would be better if the mass was removed. The thing is that you say, oh, well, it's great, we'll follow it, we'll do some CT scans and whatnot, but the patients don't always follow up. And so we adopted the policy of to take everything out, and then if the patient gets lost, they at least are as safe as you can make them, and knowing that a lot of these people won't come back, or they'll come back in a situation where they're too far gone to do anything about it.
Okay, and there is another comment about the last presentation, Prof. Is from Mary Seblik from Atlanta. She's saying preserving the nerve does not worsen the prognosis, and the patient will enjoy a better quality of life by saving the nerve. That's her comment. Okay. All right, so thank you very much for your presentations. Thank you for your contribution and your time, and we look forward to meet you for more discussion. And those who want to present for the next meeting kindly contact or reach any of us, Dr. Chege Macharia, Prof Fagan, or me, Dr. Connie. Again, I want to thank you all for taking time out of your busy schedules to be here today. And this brings meeting to the end, and thank you for your listening. The meeting is adjourned until the next month. And bye everyone, and stay safe. Thank you very much.
Thank you indeed. Thank you.
Thank you.
Thank you all.
Thank you. Thank you.
Hey, Patrick, keep well. Get vaccinated.
Thank you very much.
Jean, keep well yourself.
I got all my vaccine. I got my vaccination and the booster, so I think I'm okay.
I'm waiting for the booster.
Make sure you get off the golf course soon enough to get your booster.
It's pretty good, thank you.